Hi, good afternoon. Welcome to today's research conference at the University of Ottawa Heart Institute and also for the community. And thank you so much for joining us. We have a very exciting lecture this afternoon to look forward to. Just a few logistics. If you have any questions for our presenter, please use the Q&A feature on the bottom of your screen and post them as the lecture proceeds, and we will address them at the end of the presentation. On the other hand, you can also ask the questions directly in person at the end of the presentation. So please use the hands up feature, and then Kelsey or Allison will then unmute you, and so you can ask the questions directly that way as well. On the other hand, if you have any technical issues, please use the chat feature, and Kelsey or Allison will make sure that you can join us successfully. So we are absolutely delighted today to have Dr. Louise Sun to present a really exciting update of her work. Dr. Sun is a cardiac anesthesiologist here at the Heart Institute and also a data scientist extraordinary. And she is associate professor of anesthesiology and epidemiology and a chair in big data and cardiovascular outcomes at the University of Ottawa. She also holds the adjunct scientist position at the Institute of Clinical Evaluative Sciences, and she co-directs the Population Outcome Research Unit here at the Heart Institute. And she did her previous medicine studies at McMaster and anesthesiology residency at University of Ottawa back in 2013. And she also received her Master of Science Epidemiology from Harvard in the same time. Then she combined research and clinical fellowship in cardiac anesthesia at the University of Toronto, and then joined back here with us as an anesthesiologist, also a scientist here starting in 2015. And she is also appointed to the ICES in terms as a scientist. And she was also elected the fellow of American Heart Association recently. And she serves on the Heart and Stroke Foundation as well European Scientific Review Committees. She's an advisory board member of the American Board of Artificial Intelligence Medicine and also associate editor for the textbook on intelligence-based cardiology, which is obviously relevant for her presentation today. She serves on the AHA membership committee. She is on scientific officer of Canadian Cardiovascular Critical Care Society, the CanCare Network, and she collaborates with Core Health Ontario and the Ministry of Health on the task force for cardiac surgery and in terms of risk adjustment to the regular reports and the guiding allocation of resources. And her research is focused on the leveraging of big data, machine learning, and innovative methods and technology to tackle issues in healthcare delivery that we face every day in terms of cardiovascular interventions, patients with heart failure, and also particularly with a focus on access to care and outcomes in both men and women in cardiovascular disease, and in terms of developing personalized tools for risk stratification and defining outcomes and improving outcomes. Her work is funded by CIHR, the Heart and Stroke Foundation, Ministry of Health, and the Canadian Frailty Network, as well as our own Oracle strategic funding. And her work has been capturing global interest and interviewed with New York Times and the major television outlets and other media outlets as well. For her work, she's a recipient of the most recent Ottawa's COVID-19 Recognition Award for innovation in terms of healthcare during the pandemic, and particularly in terms of managing ICU waitlists, which is obviously top of mind for everyone at the present time. And she is the National New Investigator with the Heart and Stroke Foundation, and also Tier 2 Clinical Research Chair in terms of big data cardiovascular outcomes. And she's a recipient of University of Ottawa Junior Faculty Excellence Award, and also in terms of the Robert Roberts Award for Research Excellence here at the Heart Institute. And she was also a finalist of American Heart Association's Vivian Thomas Young Investigator Award. So this is really actually amazing accomplishment in a very short time. And we're absolutely honored to have her here and also look forward to her presentation today entitled Precision Cardiovascular Medicine Through Big Data, Informatics, and Biotechnology. Louise, the floor is yours.
Thanks so much, Peter, for the very kind introduction. I'll just try to share my screen here. And please let me know if you see any glitches.
Yeah, looks perfect.
Okay, great, thank you. So, so we know that information nowadays is key to better patient care and to better resource allocation. And data is the building block of healthcare information. So that's why today I wanted to talk to you about data as a whole and how we could use data to better manage our patients and our resources. So the outline of my talk is pretty simple. I'd like to go over what my understanding of big data is, how data could be used in clinical and health services research, and how to harness data to its fullest potential. And so first, I wanted to start with a couple of slides just as a critical look at big data for medical research. And later on, I will go in and use some recent publications from our own research program as examples of how data could be used. So first of all, what is big data? So very original here, we're stealing the words from the famous dictionary, in that data is factual information used as basis for reasoning, discussion, or calculation, and or it could be defined as information in digital form that can be transmitted or processed. So what is big data then? So big data really is an accumulation of data that is too large and complex for processing by traditional data management tools. So what that means is that big data is not just data, but it's actually the process and how we deal with the data. And it involves anything from extraction all the way up to validating data elements, storage, transfer, and any of the headaches that comes with its management. So things like access, sharing, ownership, privacy, and data analysis. And so traditionally, and this is a whirlwind tour of the definition of big data. So big data is traditionally defined by the 3 V's: volume, velocity, and variety. But there are actually since then many more V's to describe big data, which could probably fit into a separate talk of its own. There's just so much new information coming out on what big data is and how it could be used. So really briefly, types of data that are available for medical and AI type of research. We have administrative data, there are clinical registries, there are electronic health record data or EHR data, especially with the advent of Epic nowadays is becoming more and more popular, and people are investing more interest in this type of research. Text could be used as data, and there are a number of techniques for mining this data, including natural language processing. Images are basically composed of pixels, and the machine sees it as a bunch of numbers. So of course, images are data. And lastly, but not least, omics data. So proteomics, metabolomics, genomics, and so on. So basically creatively integrating these data using your clinical and your data sense are key to use the available source of data to their full potential. So I really briefly wanted to go over some of the potential applications for data in medical and AI research, and then we will go into how we could use the data to tell a story. So data could be, data visualization is basically a foundational element to how we could begin to explore data that we have. And then predictive analytics can be used in providing clinical decision support, could be used administratively, and we could do drug discovery and biomarker discovery research using big data, as well as to enhance our ability to communicate with each other and with our patients, and our ability to analyze user behavior. And lastly, medical imaging, which arguably is the most advanced area in terms of medical AI research. So there's some dissemination methods in the modern world that we could use after we use the data to find solutions for healthcare problems. And so application development, wearable technology, and integration into the EHR system are just a few of these examples of how we could use modern technology to apply the things that we learned. So real world applications, and these are some of the steps that we have discovered to help us from the project conception stage to the actual implementation stage. So first, we like to scope out source of the data that are available, and some creativity might need to be applied, and we need to know how much data is enough. So is a lot of data ever enough? It's a question that is frequently asked in the modern era. Then we have to curate the data that we have into information. And by that, again, we might need to be creative and create and validate new data elements using our clinical expertise and using this data sense. And to carve out a path where there hasn't been a path before. And to discover what is really in a data set, what missingness means and implies, which will in turn help us to deal with that missingness in the data. Then we use the information we compose from the data elements to describe challenges and to find solutions for these challenges. Then we use informatics and technology to implement the solutions that we come up with. So I'd like to begin by talking about the story that we weaved using available data in the world of heart failure. Then I will move on to cardiac surgery and cardiac interventions. So in heart failure, we use data in several different things. First of all, proteomics research. So this is actually something that we've been working on more recently. And we had a number of publications to look at RV failure biomarkers. And recently, we were able to take some of the biobank samples from a prospective study that we did a few years ago, and to look at the top RV failure biomarkers from a list of 500 plus biomarkers. So basically, a bit of background on this is that RV failure, especially in the perioperative setting, is very difficult to diagnose and treat. And any current hemodynamic markers or any kind of prediction scores give you an AUC of no better than about 60%. So not much better than a coin toss. We may have a clinician's gestalt as to who might be more prone to RV failure, but nothing predicts it really well. And so it's really crucial for us to be able to prevent RV failure, because prevention, unfortunately, is the best form of treatment nowadays. And RV failure perioperatively can be associated with up to 90% mortality, depending on the severity and the clinical situation. So it's a very deadly disease. So basically what we did was that we used a variety of machine learning approaches, and these are results, the area under the curve or AUC under the ROC curve, of the top 3 biomarkers without any clinical characteristics, so just the biomarkers themselves. You can see the results are very promising here. And the F1 score, which is the composite score of basically, your positive predictive value and so on. And so this number is indicative of the model's performance, and these numbers are quite promising as well. So we're in the middle of sorting out how to do validation studies for these patients, and eventually we would like to be able to apply it in prospective studies to improve patient outcomes in the perioperative setting. So moving on to disparities in heart failure care, this moves on to big data from an administrative sense available in the province of Ontario. So some of you may have heard of our study looking at sex differences in heart failure outcomes in Ontario over a recent 5-year period. And so just to really briefly recap, in that study, we identified the differences in risk factors for mortality in patients who had an incident diagnosis of heart failure. And we looked at disparities in outcomes in terms of mortality and hospitalization rates in women and men. And so we did a follow-up study since that, and I believe this study was published late last year, look at the temporal trend in heart failure incidence and outcomes in Ontario over a 20-year period. And so basically what we found was that each of these lines, starting from the bottom, the red, is the more historical period. And as you move up, our mortality from the more recent era. So the green is the most recent 5-year block. And you can see that these curves are for men, and there's steady improvement every 5 years in terms of heart failure mortality. But if you move over to women, the improvement is fairly dismal. So there's not much of an improvement in 1-year mortality after heart failure diagnosis in women. So that's one, that this paper had other key messages, but I just wanted to give you a very brief whirlwind tour of some of the major findings. So that's one disparity we identified. So we looked at sex disparities. What about other disparities? So in the modern era of ethnic diversity and the need for diversity and inclusion, we wanted to look at if ethnicity has an impact on patient outcomes. So basically, this is a study published about 2 years ago where we looked at South Asian Chinese versus the general population. And you can see Chinese general population did about the same. And this is 1-year survival after an acute heart failure admission. Whereas you see the mortality rates in South Asians were actually significantly better. And so again, we're only focusing on key messages here. So we went on to see if there's sex differences within each of these groups and look at the sex differences here. So Chinese group, women did probably 2.5 times worse than men. And these are I believe, standardized, age standardized mortality rates here. Whereas if you go to the South Asian group, women did a little better than men. Whereas if you look at the general population, not much of a sex-based difference there. So that's another source of disparity that we identified in heart failure outcomes that could be addressed by the policymakers and by us as the regional leader of the hub and spoke model. So what about geography? So that was our next question. And this paper looked at sex-specific and geographically specific incidence and mortality for heart failure in Ontario, in Eastern Ontario, actually, over a 20-year period. So Champlain Lynn, this is the area of our focus for this study. And really, our key message here was that women and men, we know that there are disparities, but in terms of geography, what I wanted to show you is that for certain risk factors, there actually, certain risk factors actually had a differential impact on 1-year mortality after heart failure diagnosis amongst rural versus urban dwellers, such that things such as valvular heart disease, dementia, liver disease, and metastatic cancer had a much higher risk on those patients as in the rural setting as compared to those who live in urban setting. So these are some of the disparities in outcomes. What about access to care? So this is actually a paper that is currently being written up by Felicity, one of our recently departed cardiology fellows. And this is work undertaken by Dr. Milna and I. So we here looked at, so what's your access to care in terms of time to physician review after the incident diagnosis of heart failure? And we found that, so these are broken down by women and men. And you can see that the top 2 curves represent people who were seen by physicians a little later, so 3 to 12 months after heart failure diagnosis. The middle lines represent those who were seen by a physician kind of right away within the first 3 months, whereas the bottom, people with the worst survival, were patients who were not seen at all within a year after their heart failure diagnosis. So the bottom 4 curves make sense, but the top 2 curves really could be representing the group of patients who don't have as advanced or as high acuity disease. And so we, in the paper, we did move on to discuss other factors that could be influencing our findings here. But this is just a bit of a teaser as to what type of things we've been looking at. So we've been able to use administrative data to paint the picture in disparities in access to care and outcomes in heart failure patients in Ontario. And this data in turn could be used at a system level to improve the care that we deliver to our patients. So that was a bit of a summary on some of the work we did in the last 2.5 years on heart failure. So now I wanted to move on to really briefly capture some of the work we did in terms of heart surgery and interventions. So we really all started out with our work looking at disparities in patient outcomes, looking at differences in outcomes with regards to procedure techniques. And then we thought, well, all the outcomes that we've been looking at, we're looking at what we call tombstone outcomes. So in other words, death, major adverse cardiovascular events, or MACE, and things that us as physicians care about, so we can pat ourselves on the backs and say, perioperatively, our patient did well. But can we actually create an outcome that patients truly care about, that they would trade number of years of life for, to be able to live better? So that was work on that. Then I want to really briefly go over health services research and also some of the digital technology type of research. So disparities. So this is a study to look at long-term survival after CABG surgery in women and men. And in this study, basically the key message here is that if you have heart failure, regardless of your ejection fraction, your outcome is this much worse as compared to someone without heart failure. So over here is if you have reduced ejection fraction without heart failure. So in our case handovers, in our preoperative assessments, we focus very much on the ejection fraction itself. And this study was really the beginning of me paying more attention to heart failure as an entity as opposed to systolic function alone. And if you look at the dotted lines here, these are outcomes in women. So we're consistently demonstrating worse outcomes in women as compared to men for ischemic heart disease. And so over here, we went on to try to explore why it is that women are doing worse than men. And we found that women generally waited longer for their CABG surgery, and they generally present more acutely than men. And they also suffer more complications within a year after surgery as compared to men. And these need to be explored further for us to be able to care for women patients better. So this is a follow-up study that looked at sex differences in long-term survival after any kind of cardiac surgery, not just CABG. And so basically right off the bat, we identified that women had less access to cardiac surgery in general, in that only about a quarter of women had cardiac surgery amongst everyone who had surgery in Ontario over a 10-year period. And especially anything to do with revascularization, you see less women there. So in overall, and these are adjusted KM curves, long-term survival, just little worse in women as compared to men after cardiac surgery. And these go out to about a 9-year period. So the key points in this slide is really that these are basically forest plot of adjusted hazard ratios for long-term mortality. And you can see that women did worse when it comes to CABG and CABG plus mitral valve surgery. We have a number of theories of why that would be. It just we might not have time within the scope of this talk to address them. So we delved a little further and we looked at specific types of valvular surgery. Mitral and aortic valve surgeries are really the two most common types of valvular surgeries that we do. So for mitral surgery, you can see that dotted lines again are women. So dotted lines are, yeah, so you can see that men are men. So men actually did better after mitral valve repair surgery as compared to women, whereas women did better after mitral replacement surgery when compared to men. But this kind of trend is not observed within the cohort patients who underwent isolated aortic valve surgery. You see the curves more or less are mixed in together. So those are the general disparities that we observed in cardiac surgery. So what about the influence of procedure techniques? So for us to be able to personalize our procedural-based treatments, we got to delve more into do personal factors such as age, sex, and other things influence the outcomes after certain types of surgical technique. So in this study, and this is research that Dr. Fraser Rubens and I did very recently, we looked at sex differences in CABG patients with a single versus double arterial graft. And this is basically the key figure from the paper. So these are basically inverse probability of weight of treatment weighting curves. So this is a propensity score method used to balance out two groups that you're comparing. And so basically what we observed was that mid and long-term outcome-wise, both women and men derive benefit from double arterial grafting versus single, which physiologically quite makes sense. But what is puzzling is why were early outcomes worse in women as compared to men? So basically, for women, if you survive the initial perioperative period after having a double arterial graft, then your mid to long-term outcomes are quite good. And so that actually warrants further investigations. So this is another study recently published and work done by Dr. Ruel and I. And here we looked at, again, single versus multiple arterial grafting, but this time in a specialized patient population with reduced renal function. So this is very much relevant to our practice. A lot of our patients have bad kidneys, and so whether we want to go through the higher upfront risk of more prolonged operative time to give these patients multiple as opposed to single arterial grafting is a clinically relevant question. So what we found was that in patients with GFR 30 to 60, so mild to moderately reduced renal function, we didn't see a difference. And these again these are actually propensity matched cohorts here. So the curves, you don't see much of a difference in terms of long-term incidence of MACE. Whereas if you're comparing mortality between the groups, you're seeing that the multiple arterial grafting patients had better long-term survival. So this really makes us think, although we balanced the cohort very well based on characteristics that we could deduce, in our propensity score matching, there still could have been an element of selection bias in that surgeons may have preferentially given patients with perceived better long-term survival of multiple arterial grafts. And these are patients with more severely reduced GFR, renal function. And over here, we see, which makes sense, that incidence of MACE is lower in the multiple arterial grafting group, whereas mortality is not much different. So the conclusion of this paper is that, in patients with very severely reduced renal function, we're not seeing much of a benefit survival benefit at the very least in terms of offering multiple versus single arterial graft. And in patients with moderate renal dysfunction, this is perhaps something where clinicians could sit down as a team to figure out what the best strategy would be for each given patient. So then what about comparing CABG versus percutaneous techniques for coronary revascularization? So basically, everyone's heard about the STITCH trial, and in the STITCH trial, which is the largest randomized trial to date, to look at whether CABG is better than PCI in patients with severely reduced LV function, EF less than 35%. And lots of things have changed since the STITCH era, which was more than 10 years ago. And the STITCH group cohort was also not as large as a population-based cohort could afford. And so basically what we did was that we propensity matched patients based on their likelihood of receiving CABG. And we compared the long-term survival about up to 9.5 years after their treatment. And again, in the province of Ontario, and we found that long-term survival was better in CABG as compared to PCI. So we then went on to look at each of the secondary outcomes. And so very consistently, we're seeing higher cumulative incidence of cardiovascular death, of MACE in PCI, repeat revascularization. And really the only thing where PCI patients did better was the long-term incidence of stroke. So stroke incidence was lower in patients who had PCI. This is very clinically and patient relevant, because when we go on to talk about patient-defined outcomes, you'll see that patients sometimes would they fear stroke, and to them that's a complication that could be worse than death. So for us to facilitate more patient-centered decision-making, this is something to factor into a decision matrix. So again, we're looking at, when you look at other cardiovascular complications, MI and hospitalization for heart failure, we're seeing higher incidence of these complications in PCI than CABG. So I don't want to run out of time, so I'll very quickly go over patient-defined outcomes. And so really, this research all started with us poking around in the field of frailty. And the reason we became interested in frailty was because we know that frailty was said to be a big deal in the non-cardiac surgery population, but only 3% of Ontarians who undergo major non-cardiac surgery are frail, only 3%. But when we looked at our cardiac population, we found that 24% of our patients, so a quarter of our patients, 8 times as many as in non-cardiac patients, are frail. And so that to us was big deal number one. And this is an infographic made by ICS on that publication, where we actually also found that younger patients who are frail have way worse long-term survival after their CABG surgery. So we then followed up with another study looking at all sorts of cardiac surgery, and we broke down mortality rates by surgical type. And so here, what we found was that, and these are adjusted hazard ratios here. So frail patients always did worse than patients who are not frail, which makes sense. But each procedure had a differential impact on long-term mortality after surgery in patients who are frail. And in this study, we also rediscovered the age and frailty interaction. And so to us, that was important for 2 reasons. Number one, if we were to do preoperative prehabilitation to make our patients stronger for surgery, we now know which patients to target for this intervention to get the biggest bang of our buck and to maximize benefit of prehab. And number 2, we realized that since frail patients are at such much more higher risk of dying and developing perioperative complications, maybe long-term survival is not all that patients care about. So that led to this subsequent study to look at disability-free survival. And disability-free survival was actually a term that we co-coined together with our patients. So we talked to, I believe, about 3,000 patients in this study, and we asked patients, how important do you think longevity is to you? And of course, a lot of patients thought it was important. But then we asked them questions such as, would you be willing to trade longevity to be free from stroke, to be free from recurrently being hospitalized, and to be free from being admitted to a nursing home? And many of these patients said, yes, I'd rather do that. And stroke is the most feared complication, by the way. So from there, we coined the term disability-free survival as survival free from stroke, recurrent hospitalization, and nursing home admission. And so we then applied this definition in the province of Ontario, and we saw that, again, heart failure, regardless of ejection fraction, gave you a much higher incidence of disability within a year after CABG surgery. And really the importance of this figure, this is just a replica of the previous figure, except we broke things down by sex. And the thing to pay attention to is the top dotted yellow line, where we're talking about women with HFpEF. So women with HFpEF, heart failure preserved ejection fraction, was the group with the highest cumulative incidence of disability in the year after surgery. So this is a high-risk population. So since we published that study, for me, I gained so much more respect for heart failure and not ejection fraction alone in my assessment. And every time I saw a little old lady with a very thick left ventricle, I became very vigilant in terms of my perioperative management. So this is a follow-up study examining the incidence of disability-free survival after all types of major cardiac surgery. And basically, we broke down the cumulative incidence curve by different procedure type. And what we see makes sense, because isolated CABG, bread and butter surgery, lowest incidence of disability, followed by single valve, multiple valve, and CABG plus single valve, about the same surgical risk. And this curve here. And up here is CABG and multiple valves. Complicated surgery, highest incidence of disability. This curve is interesting here, and the central message here is that the incidence of death is lower than the cumulative incidence of disability within a year after surgery. So disability is an important outcome. So finally, the last study of the series so far, and we do have more work on the go, but the last published study so far in this line of work really looks at refining this patient-defined outcome into something that both clinicians and patients are happy with and would recognize. So here we basically gathered a national panel of patients, clinicians, and caregivers, where they co-defined this definition called PACE, so patient-defined adverse cardiovascular and non-cardiovascular event, to replace MACE in our study. So you can see that it composes of some of the cardiovascular outcomes, so severe stroke, but also things like ventilator dependence, nursing home admission, new onset dialysis, and new onset or worsening heart failure. And so, anyways, coming back to the data, just for the interest of time, I might not go over all of those slides in a great amount of detail, but in working with data, really what we've learned was that going the extra mile really pays off. So knowing how the data is acquired, knowing how the data is extracted, and knowing, does the data really, is it really well suited for the question that's in front of you? Is data analysis ready, and what can you do to make it ready? So sometimes it doesn't even matter what type of data you have in front of you. It really matters most what you do with it and how much you understand it. And so that part would require very close interaction between clinician and the data scientist. So why should we care? Well, data quality directly impacts performance of the model. And sometimes, when we're training a model and when we're testing it in our own data set, the performance looks very good. But then you try to apply it on a different chunk of data or in a different set of in a different setting, the model just totally falls apart because bad data leads to ineffective modeling. And so talking about modeling, I wanted to talk about how data could also be used in the unfortunate present era of COVID, where we're balancing COVID exposure for staff and patients with delays in delivering cardiac procedures, as well as the scarce resources that we currently have. And to tackle this challenge, we use a combination of statistical modeling, machine learning, and software engineering. So this is really the first published paper of the series, and we have a couple more coming up. And basically, we derive some models for ICU resource management as well as waitlist management. The ICU models so far in prospective validation are correct about 95% of the time, whereas the waitlist management models calibrate almost right on. So almost this identical predicted numbers as compared to observed within each subcategory of surgery. So, so other health services modeling examples that we won't have time to go into are some systematic performance assessments or benchmarking. So some work that we undertook with Core Health Ontario in producing cardiac surgery report cards. So this was actually an effort, a collaboration between clinicians, administrators, as well as modeling experts from across the province, where we use routinely collected and multidimensional data to refine our predictive and risk adjustment models for assessing systematic performance. We've done some work and are still doing some work on operating room teamwork, patient safety, and provider well-being. And most of this work was actually undertaken quantitatively using administrative data, and also looking at the impact of provider handover on patient outcomes. We have done work with our collaborators to assess practice patterns and variations in delivery procedures and outcomes in the province of Ontario, as well as within US system, and also health economic assessments for different procedures and different processes of care, which I would love to share with you perhaps in a separate time. So last but not least, I wanted to introduce to you a device called Oculus. So we won't have time to really talk about it, but Oculus is really an integration. So the product that integrates predictive analytics, software engineering, and hardware design. And so this work all started out with this was actually published at the time when I was just finishing my my clinical fellowship. Where I became interested in informatics type of work, in looking at minute-to-minute blood pressure measurements, refining that data into information that will tell us how to define the threshold for threshold and duration of low blood pressure during surgery and its association with major outcomes. So this was for non-cardiac surgery. It was one of the most highly cited paper in anesthesiology. And here we were able to define the threshold and duration of hypotension association with AKI or acute kidney injury. So we followed up after I came on staff here to look at intraoperative hypotension and its association with stroke in cardiac surgery. So this paper also was quite highly cited in anesthesiology. Then we looked at hypotension thresholds and duration in association with new onset renal replacement therapy or dialysis or CRT after cardiac surgery. And we found that the post-bypass period is most critical for the kidneys, whereas the bypass and post-bypass periods were both important in terms of stroke. And so we then looked at association with hypotension with mortality. And this really, so all of this work really helped to set the stage for Oculus development, because these are really the thresholds and durations we defined, but now can we predict these thresholds? So in other words, can we put this knowledge we generated to use to actually do something about potentially improving patient outcomes? So over here, so this is Oculus. And Oculus has taken on different forms since, because this is the first prototype. The second prototype looks a little more like an iPad, mounted in a slightly different looking case. But basically, this is a machine learning algorithm that we derived to predict those critical thresholds, critical hypotension events. And we basically engineered a software to be housed within this clinical hardware to be used as a bedside monitor. And so with that, I think we're starting to, yeah, we have 10 minutes left. That's great. So thank you very much for the opportunity. And I also like to thank the informatics team. I'd like to thank the ISIS U Ottawa and ISIS Central teams for their support. Thank OHRC, my anesthesia colleagues, as well as University of Ottawa for supporting my research program and for letting me out to give talks in the middle of the day in the OR. And for all of the clinical and scientific staff here at Ottawa Heart Institute for their support, their guidance, and mentorship over the past few years. Thank you.
Well, fantastic, Louise. That's a really amazing journey, in a very short time through some really important questions, not only using big data, so really kind of look into clinical practice, looking into the outcomes, but I think you addressed the three very important areas that's very hot at the present time. One is actually people call altogether the social determinants of health, right? It's beyond the usual biology aspect, but it actually has to do with, sex of the patient, the age, the geography, the access to care, all these other aspects, which physicians don't necessarily always think about, but you can see, really actually influence the outcome in a big way. And the other one is the patient, sort of defined outcomes. I think that's really landmark and the changes to the the clinical practice, and then the ability to actually integrate this to do something useful, rather than being just descriptive. I think the Oculus and the ability to actually feedback, right, to influence clinical decision making is going to be really, really exciting. Yeah, so just fantastic. So comments from Robin Lance is the same. So it's a great presentation. Now he does have some questions, for you to consider. One is when you have a large data that come in, are there ways to, adjust for, I guess, fundamental differences? For example, I guess this is probably a reference to the PCI versus cabbage type of data, in which the referral, the patient selection might be intrinsically different. On the decision-making process. Maybe we can start with that because he does have to have another very kind of important question as well. That's from that. Yeah. So, and I was going to ask that is that, sort of, because there will be, inherent biases, in large data, and you can, specifically correct it, but you may not be able to take everything out. So how does one, sort of address that, I guess, as a general challenge, I'd say.
Thank you, and I think that's a great question. I think the solution comes in twofold in my limited experience. I think the first fold to the solution really comes in how you deal with the data that you have. So just because the data is in front of you doesn't mean it's the best combination of elements that you use to define certain data elements. And so, when people ask me, how do you define heart failure administrative data? My answer is, it depends. And it sounds like a very frustrating answer, but to me, it makes sense. And I'm not trying to be difficult. It really depends on what clinical scenario you're trying to address. So for me, even the same naming variable, it could mean very different things, amongst different studies. And heart failure as an outcome versus heart failure as a covariate in a model would mean something different as well. So sorting that out helps. And second of all, to me, I think methods for pseudo-randomization becomes pretty important. And a number of things can be done to adjust. So propensity score method is just one method that people seem to really like nowadays. So within the propensity methods, there's matching, there's inverse probability weighting, and so on. And there are instrumental variable analyses, and there are a number of other quasi-experimental designs that actually could be used as well. So depending on the scenario, depending on the data and how big the data is, what's the number of events, and what's the quality of the data, what's the pattern of missingness, some methods are a little better than others.
Yeah, so actually following up on that is, on the pseudo randomization strategy and things like that, because Rob's next question was, are there ways to potentially do like, I guess pseudo randomized trials, in these large databases, because one is always worried about the bias and the randomization is supposed to take that out. And so are there, sort of hybrid approaches?
Yeah, so I mean, there are a number of hybrid approaches. So if you're talking about purely data and no prospective data collection, then you could do those. There, like I said, there are different ways of pseudo randomization, not limited to propensity score by itself. And there are also ways of doing simulation studies, within your small or large data sets to look at, say, if this happens. What if under these conditions, what's going to happen to me in 10 years? Whereas for my digital twin, what's going to happen in 10 years if I had this treatment and if I had these lifestyle factors. So we're actually beginning to do some work on that, and the results are actually quite fascinating. So that's one way of potentially, doing a pseudo experimental thing within the databases. Another way is to integrate data that's already there with a prospective, patient group allocation, and that's really what we call pragmatic clinical trials. So basically, looking at in the real world, what happens to patients with very minimal data collection. So those are very cheap ways of doing huge randomized studies in the real world setting.
Yeah, so I think those are definitely important areas for development. And of course, in genetics, right, in terms of genomic randomizations are already established beyond doubt the power of scientific deduction there. Next question from Garish, and he's also very impressed with the amount of work you've done. And so the question is, for example, follows up on that, so do you need to follow up with randomized trials in order to, for example, influence practice? Would guidelines ever take non-randomized trials, and put that into practice? And he also has a question in terms of the insights in terms of concomitant arrhythmia, surgery in your database, relate to particularly to surgery. Yeah, and any potential data source there. Yeah.
Right, and thank you, Dr. Nair. So to answer the first question first, I think that we all know the ladder of evidence, that pyramid, and we know that people like randomized trials and people like systematic reviews and meta-analyses type of generated knowledge. But we also know that there are scenarios where clinical trials has these limitations in that, you only have so much money and so much human resources to recruit so many patients. So, sometimes you're well-powered, sometimes not really, and lots of subgroup analyses were definitely underpowered for if you're relying primarily on clinical trial generated data. So that's where population-based / real-world data really can come in to help. And so, in some scenarios, that's the case. In some scenarios, you cannot ethically really randomize patients to one treatment to another. So that's another way for big data sets to come in handy. So I don't think these can completely replace randomized trials. And certainly there's always going to be an element of residual confounding, within observational study designs. But modern methods are becoming more and more advanced in correcting for that. So there's definitely going to be a role for comparative effectiveness studies using observational data. And there's always also a role for pragmatic studies to expand the horizons of RCTs. For the second question, the concomitant arrhythmia surgery, we definitely have information on that. with a lot of our recent studies, we've been sort of excluding those just because classification of different surgery procedures become a little messy, but certainly we have procedure details on those.
Yeah, Gurish will help you out on those. And
Yes.
no, Mark, do you want to ask your question directly? Otherwise, I'll ask it for you. Okay, so then maybe I'll ask Mark, because you really enjoyed your talk, and he, I think was going to, there's Mark coming on. So Mark, do you want to ask the question directly? Yes.
Hey, Louise, this was great. Thank you, Peter. So Louise, wonderful work. Such a great program in such a short time, as Peter was saying. The falsification endpoints, very powerful, right? And we often go, as you know, many journals, I'll give you one example, Circulation, will say we won't take anything observational with regards to comparative effectiveness unless there's no trial in the field. As soon as there's a trial in the field, it becomes relevant. But then, how do you eliminate indication bias and residual confounding? And one great way, and I know you've used it so well, and I learned it from you, is falsification endpoints. But it does influence what you measure, right? If you have a mitral valve repair database and Vince follows these patients forever, he kind of has to make sure that he's going to pick up pneumonia and hip fractures and this and that, right? So it becomes very, very difficult to have the foresight at the inception to be able to capture this. Any recommendations outside of having access to the entire ISIS database? Thank you. It was a great talk, Louise.
Thank you. So, the last phrase that you put in there, Mark, kind of took away the answer I was going to say. And, the original answer I was formulating was that, at initial inception, it's good to capture as many outcomes as you can, but then, those databases, although they're very good in accurate granular detail, what they could possibly lack is loss to follow-up data, right? So, if your patient moves away, you don't have their number anymore, they decided they didn't want to answer your phone calls anymore, then you may lose capture in terms of their outcomes. Whereas with larger administrative data, the beauty of it is lack of loss to follow-up. So for ICS, as long as you still reside in the province of Ontario, no matter where you are, if you go to the hospital with a hip fracture, we know. If you're residing in Canada still and you're hospitalized for hip fracture or pneumonia or UTI, we know that. And so, that's sort of the beauty of it. And you can always integrate local granular databases with the administrative data. It doesn't need to be ICS. It could be something else to be able to capture those outcomes with more completeness.
Louise, do you want to tell our trainees what you would recommend, how you would describe falsification endpoints? I'm sure not everyone knows. I certainly, several years ago, I would not have known what they are, right? And I think they're quite a powerful observational tool, and you've mastered it so well. So I think we want to hear it from you.
Thanks, Mark. So falsification endpoints are really endpoints that are not the endpoint of interest. And so, for instance, if I'm really interested in what's the association of, say, I don't know, ejection fraction with long-term mortality after CABG surgery. And so over here, my outcome is mortality. But the thing is, people who are more prone to dying may also be more prone to some other complications, right? And really, does it really just have to do with ejection fraction, which was my main exposure of interest, or does it really have to do with something else along the causal pathway? And so falsification endpoint is really using something that's completely unrelated to death. So hip fracture is really much related to death. So hip fracture is out of the window. But if you're looking at something like hangnail, or if you're looking at, something like a UTI, make that as your outcome. So that's called your falsification endpoint. And see, is there still an association between ejection fraction and a fungus nail infection, just to make it up? There shouldn't be, but if there is, then there's something going on with your model that you should take a look at. So totally unrelated outcome, just to make sure that your model is not contaminated with other signals.
Yeah, I think that underscored the point of the biological rationale, sort of the the underlying, sort of understanding of disease condition is still super important beyond the statistical modeling. Maybe we'll have the final question. I know we're going over time, but Dr. Masana has a question that is that how do you draw the line these days between, say, complex statistical modeling and AI analysis, because there are obviously a lot of boundary that's actually crossed by each. Yeah.
Right, and that's a great question, Dr. Masana. So what I would say is that, I see myself as someone who's trained from the statistical side, but because of my background training in biomedical engineering and programming and mathematics, I took an interest in machine learning type of predictive analytic approaches. And what I have to say is that a lot of them do overlap. We use different terminologies to describe more or less the same thing a lot of the times, for one. And for two, what I do sometimes is that I actually try a variety of modeling approaches when I'm trying to say, model length of stay, when I'm trying to model mortality, and just whatever it is that might be. And I basically take the model that gives me the most consistent approach, that's the most simplistic, and that performs the best. And so, a lot of the times there are lots of overlaps in the techniques, and they could be integrated. Sometimes we do what's called a hybrid modeling approach, where we take a go at it, we chop down the number of variables with some kind of tree-based technique, so from the machine learning side, and then we plug it into a more traditional regression model for parsimony and also for explainability, right? Because people are worried about machine learning as a black box, and I don't know what goes in, I don't know what comes out. So basically, we put the explainability back into this. So we do that kind of stuff as well.
Yes. And I think it's really, a luxury of access to tools, and the consistency, right? And the insight will really help us to move forward to get to the best methods for the best answers to the question. So I'd like to, I know we are all way over time, but just like to thank Louise for a fantastic presentation. And of course, the work that she's doing, that's so important, not only for all of our, sort of clinical practice and our interests, but also, in terms of helping a diverse group of researchers, to achieve very, very important answers, to questions that we all have a great interest in, and of course for our patients, and it really enhances collaboration across many, many domains. Yeah, so I'd like to thank Louise for her outstanding work, and so poor Louise, doesn't have time for lunch or anything else, but we appreciate every minute of her work. So thank you, and thanks for joining us. Really appreciate it. And there won't be any rounds the coming week because it's Victoria Day weekend, and so enjoy that. And we will see you again in 2 weeks. Take care. Bye-bye.
Thank you.